Hello, everyone. Right, so this time I'm back with some important talks for your MRCOG Part 2 revision. So stick by and hopefully we can learn something together. The first TOG article is the perforated uterus. Very, very important TOG. So the key content says uterine perforation is an uncommon but potentially serious complication of uterine manipulation, evacuation of retained products of conception or termination of pregnancy, hysteroscopic procedures, and during coil insertion. Factors that increase the risk of uterine perforation include uterine anomalies, infection, recent pregnancy, and postmenopause. Termination of pregnancy is the most common procedure associated with uterine perforation. Prevention of uterine perforation is favored, although if it occurs, initial recognition together with immediate and ongoing management is key to reducing morbidity, mortality, and long-term consequences. It is important that surgeons performing surgical termination of pregnancy are adequately trained. The experience of the surgeon results not only in fewer perforations but also in the early recognition of uterine injury. Uterine perforation is a complication that is well recognized by all gynecologists, although subsequent assessment and management needs to be standardized. So, uterine and cervical factors that increase risk of perforation, so advanced gestation when termination of pregnancy is performed, ERPC for postpartum hemorrhage, so evacuation of retained products of conception, parous uterus, recent pregnancy in the past 6 months, small postmenopausal uterus, tight postmenopausal cervix, uterine cavity distorted by fibroids, intrauterine sync or adhesions, pyometria, infection, position and attitude of the uterus, retroverted, acutely anteverted or retroflexed uterus, uterine anomalies, and the scarred uterus, previous uterine surgery. Incidence of uterine perforation with the use of various instruments. So with a suction cannula, the incidence of perforation is the highest, which is 51.3%. Hager dilators is 24.4%, with a curette is 16.2%. Common sites of uterine perforation and their incidence. Anterior wall is 40%, so the commonest site of perforation is the anterior wall of the uterus. Cervical canal is next, 36%, right lateral wall is 21%, left lateral wall is 17%, posterior wall is 13%, and the fundus is 13%, the lowest. So, what do you do when you recognize a perforation? So, if the instrument that you've used is a dilator or a 5 mm hysteroscope or a curette or a coil or wild coil insertion or a polyforceps, then you should alert your team. Plus or minus, you put a urinary catheter, observe the patient, give some antibiotics, plus or minus senior help, depending on if the patient's bleeding or not. If there's no bleeding and the patient's stable, then discharge when stable and arrange follow-up, risk management and incident form, alert patient to signs and symptoms that may require readmission to hospital. If the patient is, however, bleeding or unstable with any other complications, then a laparoscopy is required. If it's a small perforation, is not bleeding and no other injuries, then again, discharge when stable and arrange follow-up, risk management and incident form, alert patient to signs and symptoms that may require readmission to hospital. If the instrument that you're using is more than 5 mm scope, or is avulsion attempted, or resection, loop, or laser, or surgical termination of pregnancy, or evacuation of retained products of conception, then alert the team, put a urinary catheter in, observe the patient, give antibiotics, get senior help. Plus or minus, you may need involvement of other specialties like a bowel, colorectal surgeon, or urology. Perform a laparoscopy if the perforation is small. Again, follow the previous thing, which is and they're not bleeding and there's no other injuries, and discharge when they're stable and arrange follow-up, risk management, incident form, alert patient to signs and symptoms that may require readmission to hospital. If there's a large perforation, it's bleeding, other injuries have happened or they're suspected, then repair the injuries laparoscopically. If a laparotomy may be required, if these injuries cannot be repaired or laparoscopically, and then admit the patient for at least 24 hours. Right, next talk is hormone replacement therapy following treatment of gynecological malignancies. Approximately 21,000 women in the UK were diagnosed with a gynecological malignancy in 2015. Although most of these malignancies occurred in postmenopausal women, 30 to 40% are present in premenopausal or perimenopausal women. Management typically involves surgery and/or chemotherapy and radiotherapy, which in younger women may result in an induced menopause. Many women struggle with both the immediate symptoms and the long-term consequences of estrogen deficiency, all of which are debilitating and compromise the quality and the quantity of life, in addition to the cancer diagnosis and treatment. These patients represent a complex group, and most units in the UK do not have any access to menopause specialists. Gynecologists may be reluctant to prescribe hormone replacement therapy to these women. Clinicians involved in the care of these women must appreciate when HRT is and is not contraindicated. Very, very, very nice green table here. This is a summary of evidence and recommendations for practice. So for ovarian cancer, if it's like a epithelial type of cancer, there's no evidence that HRT increases recurrence or decreases survival. May be beneficial, but data are limited. HRT recommendation is limited data. Germ cell ovarian cancer, insufficient evidence. So it's the recommendation for HRT is to avoid. With sex cord stromal ovarian tumors, again, insufficient evidence. The HRT recommendation is to avoid again. Borderline ovarian tumors, again, insufficient evidence, and the recommendation is to avoid or use cautiously. With endometrial type 1 endometrioid cancer, stage 1 and 2, there's no evidence that HRT increases recurrence or decreases survival. Estrogen only if no concerns of possible occult foci, otherwise continuous combined. With stage 3 and 4, there's insufficient evidence, so the recommendation is to avoid. With type 2 endometrial cancers, there's insufficient evidence again, and the recommendation for HRT is to avoid. With cervical squamous cell carcinomas, stage 1 and 2, no evidence that HRT increases recurrence or decreases survival. Again, with HRT recommendation, estrogen only if previous hysterectomy, otherwise continuous combined. For cervical stage 3, there's insufficient evidence, and the advice is to avoid or use cautiously. With cervical stage 4, again, insufficient evidence, and the advice is to avoid or use cautiously again. With adenocarcinoma of the cervix, insufficient evidence again, and the advice for HRT is to avoid or use cautiously. With vaginal squamous cell carcinomas, no evidence that HRT increases risk or of recurrence or decreases survival. Again, estrogen only if previous hysterectomy, otherwise continues combined. With non-squamous cell vaginal cancers, insufficient evidence, and the advice is to avoid HRT. With squamous cell vulvas, no evidence that HRT increases risk of recurrence or decreases survival. Estrogen only if previous hysterectomy, otherwise continuous combined. Non-squamous cell vulval carcinomas, insufficient evidence, so the advice is to avoid HRT. Headaches in pregnancy. Headaches in pregnancy and the postnatal period are common and usually benign, but can herald intracranial catastrophe. Assessment of headache in pregnancy is an essential skill for obstetricians and the general practitioners. Pregnancy can alter migraine aura and may trigger attacks of aura without a headache. Headache may be the only symptom of cerebral venous thrombosis. If cerebral venous thrombosis is suspected, expert opinion should be sought and urgent brain imaging considered. Neurological conditions were the third most common cause of death and ahead of sepsis in the confidential inquiries into the maternal deaths in the United Kingdom in 2006-2008 report, when considering direct and indirect causes. Key causes of headaches in pregnancy. So primary causes are migraine and tension headaches. Secondary is hypertension, subarachnoid hemorrhage, drug-related like nifedipine, medication overuse, postural tap, meningitis, cerebral venous thrombosis, anemia, caffeinated withdrawal, idiopathic intracranial hypertension, stroke, arteriovenous malformation, enlargement of pituitary tumor, enlargement of a hormone-sensitive tumor, example meningioma, bleeding into pre-existing tumor, cerebral metastasis of choriocarcinoma. Postural puncture headache. Puncture of the dura occurs in 0.5 to 2.5% of epidurals. So puncture of the dura occurs in 0.5 to 2.5% of epidurals. If accidental dura puncture occurs with an epidural needle, there is 70 to 80% chance of post-dural puncture headache. The headache is usually in the fronto-occipital region and radiates to the neck. It's characteristically worse on standing and typically develops 24 to 48 hours post-puncture. Conservative management includes hydration and simple analgesia. Untreated, the headache typically lasts for 7 to 10 days but can last up to 6 weeks. Epidural blood patch has a 60 to 90% cure rate. Red flag features for potentially secondary headache, thunderclap headache, so rapid time to peak headache intensity, seconds to 5 minutes, example with a subarachnoid hemorrhage, focal neurological symptoms, example limb weakness, aura less than 5 minutes or greater than an hour, non-focal neurological symptoms like cognitive disturbance seen in central venous thrombosis, change in headache frequency, characteristics or associated symptoms, abnormal neurological examination, headache that changes with posture, a sign of high or low cerebrospinal fluid pressure, headache awakening the patient associated with migraine and raised intracranial pressure, headache precipitated by physical exertion or Valsalva maneuver, considered subarachnoid hemorrhage or raised intracranial pressure, patients with risk factors of severe cerebral venous thrombosis, jaw claudication or visual disturbances associated with giant cell arteritis in women over 50 years, fever, consider meningitis, neck stiffness, indicative of meningeal irritation, new onset of headache in a patient with a history of HIV infection, new onset in a patient with a history of cancer. This is a picture that shows papilledema. Look for pinkiness of the disc with blurring and heaping up of its margins. There's loss within the disc of the normal pulsation of the retinal veins. The disc becomes engorged and its vessels become dilated. This is an image from the TOG article and from the University Hospital of Southampton. Diagnostic criteria for headache attributed to preeclampsia or eclampsia. So headache in a woman who's pregnant or in the puerperium, fulfilling criteria C. Preeclampsia or eclampsia has been diagnosed. Evidence of causation demonstrated by at least two of the following. Headache has developed in temporal relation to the onset of the preeclampsia or eclampsia. Either or both of the following. Headache has significantly worsened in parallel with the worsening of the preeclampsia or eclampsia. Headache has significantly improved or resolved in parallel with improvement in or resolution of the preeclampsia or eclampsia. Number 3, headache has at least two of the following three characteristics: bilateral location, pulsating quality, aggravated by physical activity. D is not better accounted for by any other ICHD3 diagnosis. Key points in imaging of the head in pregnancy: the accepted background accumulated dose of ionizing radiation during pregnancy is 50 mgy. Fetal exposure for a CT scan of the head is estimated to be less than 0.005 mgy. MRI should be avoided in the first trimester because of the potential hazard of hypothermia and acoustic noise, but MRI remains preferable to any other studies using ionizing radiation. Contrast media based on the element iodine should be avoided in pregnancy unless essential. If iodinated contrast media are used in the neonatal thyroid function should be checked. Gadolinium-based contrast agents appear to be safe in pregnancy. Lactating women who receive iodinated contrast or gadolinium can continue breastfeeding without interruption. Diagnosing pathophysiology and management of premenstrual syndrome. An overview of current information available on premenstrual syndrome, which is in accordance with the new RCOG Green Top Guideline, definition of PMS and explanation about the different types of premenstrual disorders, how to accurately diagnose PMS, discussion about various treatment options available in accordance with the current literature. Criteria for diagnosing core premenstrual disorder: it is precipitated by ovulation. Symptoms are not defined, although typical symptoms exist. Any number of symptoms can be present. Physical and psychological symptoms are important. Symptoms recur in the luteal phase. Symptoms disappear by the end of menstruation. A symptom-free week occurs between menstruation and ovulation. Symptoms must be prospectively rated. Symptoms are not in exacerbation of an underlying psychological or physical disorder. Symptoms caused significant distress and impairment of daily activities such as work, commitments, social interactions, and family activities. So, item content of the daily record of severity of problems, DRSP. Felt depressed, sad, down, or blue, felt hopeless, felt worthless or guilty, felt anxious, tense, keyed up or on edge, had mood swings, example, suddenly felt sad or tearful, was more sensitive to rejection or my feelings were easily hurt, felt angry, irritable, had conflicts or problems with people, had less interest in usual activities, example, work, school, friends, hobbies, had difficulty concentrating, felt lethargic, tired, fatigued, or had a lack of energy, had increased appetite or overate, had cravings for specific foods, slept more, took naps, found it hard to get up when intended, had trouble getting to sleep or staying asleep, felt overwhelmed or that I could not cope, felt out of control, had breast tenderness, had breast swelling, felt bloated or had weight gain, had headaches, had joint or muscle pain, at work, at school, or home, or in daily routine. At least one of the problems noted above caused reduction of productivity or inefficiency. At least one of the problems noted above interfered with hobbies or social activities, example, avoid or do less. At least one of the problems noted above interfered with relationship with others. The transgender population, improving awareness of gynecologists and their role in the provision of care. The UK's transgender and non-binary population is expanding, and this is reflected in the annual number of referrals to gender identity clinics. Gender identity clinics offer a wide range of care to transgender patients, including hormone treatment and gender reassignment surgery. However, increased demand has led to long waiting times for these clinics. All transgender patients who wish to transition should be offered a fertility consultation to explore their options, which may involve fertility preservation, such as sperm or oocyte cryopreservation. Gynecologists form a part of the multidisciplinary team who engage with transgender and non-binary patients, either as part of the transgender transition stage, performing surgery, or managing pre or post transition gynecological problems. Gynecologists should be aware of the potential barriers to healthcare often faced by transgender patients and how the way in which patients are addressed during a consultation can improve their experience within the healthcare system. Opinions of and eligibility criteria of transgender patients. There is persistent and well documented gender dysphoria. The patient has the capacity to make informed decisions and give consent. Any significant medical or mental health concerns present are reasonably controlled. The patient has a realistic, achievable plan that has either been implemented or is about to be implemented at an established and agreed time. Testosterone therapy available. So testosterone esters, 250 to 500 milligrams by IM injection every 2 to 6 weeks, depending on serum levels. Testosterone enanthate, which is 250 to 500 milligrams by IM injection for those with peanut allergy every 2 to 6 weeks. Testosterone gels is 5 milligrams daily. Testosterone undeconate 1 gram every 10 to 14 weeks by IM injection. Estrogen therapy available is estradiol oral tablets 1 to 6 milligrams daily, estradiol transdermal gel 2 to 4 again 5,500 microgram measures daily, estradiol patches 550 to 150 micrograms twice weekly. Gender reassignment surgery for trans women includes penectomy, orchidectomy, vaginoplasty, clitoroplasty, labioplasty, cricothyroid approximation, thyroid cartilage reduction, breast augmentation, feminizing facial surgery. Gender reassignment surgery for trans men, bilateral mastectomy and chest reconstruction, hysterectomy, vaginectomy, salpingophorectomy, metoidoplasty, phalloplasty, urethroplasty, scrotoplasty, implantation of penile or testicular prosthesis. Okay, perinatal mental health, how to ask and how to help. In 2015 Mothers and Babies Reducing Risk through Adult and Confidential Inquiry, so Embrace report states that death from psychiatric disorders is now one of the leading causes of maternal death, surpassing hemorrhage, preeclampsia, and genital tract sepsis. Perinatal mental health is stigmatizing to women and professionals alike, leading to reluctance to discuss the topic and under or misdiagnosis. Often clinicians may feel apprehensive in broaching the subject for fear of asking questions insensitively, or perhaps not knowing what to do with the information divulged. Red flag presentations include a recent significant change in mental state or emergence of new symptom, new thoughts or acts of violent self-harm, new and persistent expressions of incompetency as a mother or estrangement from the infant. Psychiatric history presenting complaints of mood, anxiety, psychotic symptoms, memory, cognitive function, history presenting complaint, timeline of symptoms, third-party sources available, past psychiatry history, previous or current diagnosis, self-harm or harm to others, previous admission, use of mental health act, previous treatments and outcomes, past medical history, cardiac, renal, liver, etc., drug history, allergies, any psychotropic medications currently and previously prescribed, and adverse effects experienced, family history, family tree, family history of psychiatric illness and self-harm and suicide, smoking history, smoking status, alcohol, illicit drugs, housing and occupational information, including financial strains, personal history, birth, development, childhood, school, relationships, family, parents, and romantic and sexual in employment, forensic history like convictions and contact with police, pre-morbid personality, how would others describe your personality when you are well? Mental state examination. So while these notes are a brief guide, it's important to remember that describing in detail what you see and hear is the most important aspect of a mental state examination. So appearance and behavior, describe dress, personal hygiene, any use of features like wearing multiple layers and coats indoors. Are they polite, rude, anxious, aggressive, or evasive? Speech, rate, fast, slow, variable, rhythm, flowing, disjoint, volume, tone, coherent or relevance, mood, record subjective mood, verbatim, awful, doctor, and the objective mood, like low, manic, mixed, affect, is this reactive and congruent? Thoughts, delusional thoughts, thought disorders, anxieties, overvalued ideas, and other psychopathologies. Describe what you see and hear. Thoughts of self-harm and harm to others are included here. Perceptions, hallucinations, auditory, visual, tactile. Describe in detail auditory hallucinations in second or third person. What do they say? Do they give commands? Cognition, orientation to time, person, place, memory, concentration and attention. Insight, what is their perception of any symptoms? Do they want help? Record compliance with medications and treatments. Um, Simple lifestyle advice for mild, low mood and anxiety, sleep hygiene, waking and going to bed at the same time every day, avoiding coffee after 5 p.m., avoiding screens after 8 p.m., hot drinks, reading in soft light, meditation before sleep, managing hyperemesis, small regular meals, good hydration, ginger-based tea or biscuits, regular antiemetics, reassure safe in pregnancy, importance of regular gentle exercise, engage in a class for social interaction, a structured group physical activity program, encouraging self reflection on a particular anxiety issue, try to understand why it's troubling the women, signposting to services in the community like mindfulness meditation, specialized support groups for pregnant women, yoga, mother and baby yoga, swimming classes, individual guided self-based therapy on the principles of the cognitive behavioral therapy, books, leaflets, and computerized cognitive behavioral therapy. Key points: how to ask, make the first encounter count, establishing a rapport using neutral, open questions to assess breadth and severity of symptoms, establish a trusting and therapeutic relationship, take cues and probe for more information based on the individual's presentation, ask specific and direct questions to establish risk, active communication between obstetricians, mental health midwives, community mental health team, GP, and women about her mental health, recap of psychiatric history and examination, how to help optimize all encounters to be therapeutic, provide front door lifestyle advice to support mild to moderate anxiety and low mood, establish risk to direct referrals appropriately, facilitate admission if necessary, dispel stigma for the wider knowledge and understanding of perinatal mental health. Well, that's it for now. I will be making another part two of this video to include some more important talks for revision of MRCOG part two. If you found this video useful, then please give it a thumbs up and subscribe to my channel so you can keep yourself updated with more content that I'm uploading.